questions along the way. I would much rather, you know, have interruptions than have confused audience members. So I'm happy to do that. And this work is joint with Lindsay Page at the University of Pittsburgh and Eleanor Martin, who is a PhD student here at Michigan at our School of Education. So with that, oh, I'm gonna click something. Okay. With that, I'm going to just jump in here. Okay. So just a little background on this topic, right? So why target moms who are new and in this way? So basically this transition to parenting, or into some cases to having a second child, because we are focusing on first and second time moms in this trial, is a time of both risk and opportunity, right? So on the risk side, when a new baby enters the family ecology, you have a host of situational challenges as well as physiological challenges brought on by the birth that can lead to increased stress for the mother and the family, and not infrequently to depression. We also know that we're in a time when parents feel quite criticized, especially moms. There was a really nice piece of work out of Mott, actually in 2017, that kind of quantified the degree to which parents feel really criticized. We also know that these early stressors can impact the kids. So we see some negative relationships between the kinds of stressors parents are feeling when they're heightened in child behavior, and some disruptions in attachment are also possible. Now, the opportunity side of this is that relative to most of the life course and adult development, new moms are actually really unusually open to change. So there's been some really interesting work looking at the neuroscience behind the brain at childbirth, and we actually see some structural changes. And we've also seen companies like Target really leverage this time because spending patterns, for example, really are open more than any other time. And so companies have been able to leverage this. And so it's interesting to kind of see how with tech interventions, we might be able to also do so as well. And so this tech intervention space is sort of an interesting way to access parents. So we're at a time where virtually all adults in the US have access to a cell phone, including those who are lower income. We also know that parents increasingly turn to the internet for guidance and support. They think it's reliable and convenient, but they do report concerns about the reliability that they find, as well as being overwhelmed by the amount of stuff that is out there, right? And so tech interventions have kind of realized that there are these opportunities that parents do view this as potential support, but have some problems navigating all that's out there. And so at this point, a review of the 48 tech-based interventions for 0 to 3-year-olds in 2015 by Hall and Bierman came up with the following findings: that there's really a diversity of things that people are doing to support parents with technology that focus on improving parent behaviors, knowledge, and well-being. And this really ranges from websites to text messages to video conferencing and online coaching. And across these, the research is really in an early stage. There are 23 out of the 48 studies have addressed program impacts, and the results are really mixed. So 12 studies found statistically significant improvements on targeted outcomes, and those range from things about the parent's behavior to and well-being to child development, and 11 found no statistically significant effects. Now, a real gap in this literature is that while folks have looked at impacts, there's been very little on how parents are engaging with interventions. So this is, again, one of the reasons that we're really trying to focus on how people are using this, what are they taking from it, what are they finding valuable versus less, because we need to know kind of the inside the box side of these interventions too, so that we don't just do program evaluations from one, but really take the learnings across them to improve future ones. Okay, so our intervention is text messaging only, although ours has a mentoring component. And so this has been less done in the early childhood space, but it has been done quite a bit with parents of school-age children as well as college-bound students. And so these kinds of text-based programs, from everything around check your child's homework to work with your child around letters and numbers to here's how you complete a FAFSA form to get into college. This has shown some effects, in some positive effects in some studies. In 0 to 3, we just have text for baby that's been rigorously evaluated, where parents receive a pre-programmed message covering health and safety topics 3 times a week for the first year of life. And we have seen some evidence from that intervention that this kind of one-way pushing out of information around these topics has led to positive effects on parents, like maternal beliefs of self-efficacy, increased knowledge in infant health, and to reduce postpartum alcohol consumption. So there's been less on text for baby about whether that's really translating to improved child development outcomes and whether it's also getting to parent-child interactions. So that's kind of where ours comes in. So we have a partnership with a Pittsburgh nonprofit called NurturePA, and they have a text-based mentoring program for new mothers in which the mother and baby are matched with a mentor at birth. And the mentor basically isn't just kind of texting at will with the mom. They're trained, they are a volunteer, but they are trained on the kinds of topics, and then they are also supported on their end. They're not just on their phone, they're actually on a tablet within an app that has recommendations that are from the American Academy of Pediatrics, Bright Futures, 0 to 3, sort of authoritative sources like that. And the app is programmed so that when the mentor is working with a particular mom, the content that comes up has pre-programmed messages to draw from, although they're encouraged to customize them so it's more conversational, tailored to the baby's age, right? So at 6 months, you're going to be asking the mom about different things than 9 months, for example, and that's meant to streamline and be easy for the mentor and to match guidance around the milestones around what the baby would be working on at a different developmental period. So the mentor training is about 3 hours. It's an in-person, well, it used to be in person, obviously, back before the pandemic. And then they complete 7 hours or 7 online training videos that add up to about 2 hours of time. Things like breastfeeding, for example, best practices for supporting new moms in that area. And so the mentor is told to answer the mother's questions, provide information about area services and resources, and encourage these practices that support child development. And they are really also focused on just telling the mom that she's doing a good job, right? So your baby doesn't sleep like your sister-in-law's baby. It's not your fault. Some babies are just hard, and to share kind of stories about their own children, about how X period that was difficult was for that mom was difficult for them too. So this is sort of a simplified theory of change around how we have hypothesized that this intervention might be benefiting moms and babies. So the key ingredients here are that the mother, through this relationship, is getting information at the right time when it's salient to her, right? So they're getting 3-month information when the baby's 3 months. Positive reinforcement. So the mentor is, again, trained to give emotional support and provide positive feedback when the mom reports she's doing a particular activity. Tailored to the child age and mother needs, and the links to the resources. So that looks like, here you can go to this baby story hour. Well, it used to look like that. Now you can go to this online baby story hour. But in our trial, mostly it was the in-person time given our timing. And we've hypothesized that these will lead to benefits like increased maternal knowledge of child development, more sensitive and responsive caregiving, and improved maternal well-being. And hopefully that will lead to benefits for children, particularly in language and socio-emotional development. Okay, and in terms of the theory of this from the adult development side, this intervention is matching the tenets of adult learning theory around the learning being really applicable to what's happening in your daily life. So leading to reflection between, what you're seeing versus what are you doing. You have somebody to discuss what you're seeing and any questions you have about implementing something that's been suggested. as well as active involvement. So it's something that you can do. Basically, you know, it's a kind of easy way to put all that adult learning theory into a statement is that adults like to learn, but they don't like to be taught, if that makes sense. So they like to kind of have these hands-on experiences that are really salient and be very active participants in their learning. That's kind of where this comes. This is also really judgment-free. So this is someone you never meet who's always very supportive of you, essentially, right? And so this is really different from the kinds of experiences that we know parents are having as they go out and about in the world. And it's also meant to address behavior complexities. So breaking down tasks like how, you know, there are a million things I could be doing to support my baby's development. When I look on the web, it's really overwhelming, and my mentor is saying, do this one thing right now to reduce that task complexity. And also in terms of delayed gratification, some of the things like reading books to your baby, you're not going to see the results of that for a while. So you have someone telling you that, you know, that's a good thing to do and it's going to lead to things down the road. So it's sort of helping with delayed gratification issues that your brain is kind of wired to do things that are more salient, where the return is more immediate or you have evidence of it. Okay, and it is within this nudge literature as well that, you know, here is a way, a reminder to engage in these things when you're busy. Okay, so what does the intervention actually look like, given all that I've just told you? So this is a sample exchange around that we see in the text message transcripts, because we have all of these. This gives you a sense of what a maternal well-being interaction might look like. So what you see here, and I'll just kind of go through the bold, that the mentor is kind of nudging the mom to take some time to rest and to prioritize self-care as well. And the mom is saying it's been really hard. She's been feeling really stressed. She hasn't been able to find energy or motivation to kind of go out and jog like she used to. And the mentor is saying, oh, I'm sorry, things are a little rough. Maybe you should talk to your doctor. And the mom says, I'm not really comfortable doing that right now. And the mentor offers to help connect the mother to a doctor or a therapist, okay? On the child development side, this is one from language development, where the mentor could have an opening where she says, okay, I just want to share this information with you about why it's so important to talk to your baby. You can see all this detail here, but the important point is it really helps their language development. Do you talk to your baby Ace a lot? Do you feel silly? And the mom says, oh, I try, but I feel kind of silly because the baby doesn't answer back. And then the mom kind of reinforces that with her own child, she felt the same way, but it really did help. And, you know, that it's the right thing to do, essentially. So these are the kinds of exchanges we see in our trial and in a feasibility study we did with this nonprofit using their data and their text transcripts well before we went to the trouble of a randomized trial. Okay, so the randomized trial that we're doing takes place within West Penn Hospital, a research hospital in the Pittsburgh area that has about 4,000 births a year. We recruited about 200 moms, 99 treatment, 100 control, and from them we drew a qualitative subsample for interviews that consists of 28 moms, 24 treatment moms, 4 control, and we also interviewed 10 mentors to get a sense of the intervention from their end of things. The treatment condition is that you can be randomized from your hospital bed into getting the mentor, as I've described it, across the first 18 years, and you can write to the mentor as you wish at any time to get answers to your questions. The control condition is that we give the control moms a one-way text about safety, health, or motor development milestones. So we are trying to rule out essentially that it's not just about being able to push out kind of basic health and safety information, that's going to lead to these changes or to getting any kind of text touch, that it's really about getting a supportive mentoring relationship that goes beyond these kinds of basic guidance principles. And we did start recruiting moms in May 2018 and had a rolling enrollment period through September of 2019. And our study is pre-registered, so we're analyzing data as we thought we would from the beginning. Okay. And our moms had to be residents of the city of Pittsburgh or Allegheny County, give birth at West Penn to a baby whose gestational age at birth was at or above 34 weeks, whose birth date was at or above 4 pounds, and the child was leaving the hospital with the parent with no extended NICU stay. The plan was to, the mom also had to plan to continue to live in Pittsburgh, Allegheny County for at least 2 years to facilitate our finding them. And also because we know local resources, referrals are important within this intervention, that could occur. Hopefully that they wouldn't leave Pittsburgh. Care for no more than one other child in the home, including non-biological children. So we were really focusing on first and second time moms here, and no history of substance abuse or disorders. If any of these, as medical researchers, stick out to you as unusual or surprising, we would love that feedback. This is our first time as a team working in a hospital setting, and we came up with these and they seem reasonable to us. But if we've somehow made our external validity strange with these, that would be great feedback that people could feel free to weigh in with now or later.
I had a question. Did you notice any difference between those who did and didn't enroll?
So we don't have data on that. So we had to go through the hospital and had a clinical coordinator. And, there was like a whole screening process to get from those 4,000 births to who was even eligible, which was a big drop off. And then we weren't able to have data about those who said no, unfortunately.
I've been amazed at how many moms have substance abuse disorders. Especially, I've been amazed. I guess one question is, did you consider marijuana a substance abuse disorder?
Well, I don't think that would have appeared in any of their medical records, right? Unless, well, okay, if it appeared in their medical records as a substance abuse disorder, they would have been screened out.
Okay. I feel like I've seen more and more moms who are on marijuana. I don't know what it's like in Pittsburgh, but as it's being legalized, I don't know if that's why it is, or if it just happens to be I'm seeing more moms with marijuana and maybe they end up with some neurological disorders, and so I see them. But yeah,
that's interesting. Yeah, I should check the when the law changed, or even if it has in Pennsylvania. I'm not sure, but that's good. Yeah,
it may be that people, because it's now legal, people are admitting it too.
Christina, this is Kevin Umkowski. I have a quick question. A couple slides back, you, I think, said that you did qualitative interviews, and it looked like there was sort of an imbalance there. You had like 20 some moms in the study arm, but only 4 in the control arm. Did you have trouble recruiting from the control arm, getting people to participate? It sort of speaks to the fact that you maybe have a little less information about those who weren't exposed to the intervention.
So we did not. So that was just a design thing. So we actually had really good response, right? So we offer people $100 to talk with us on the phone for a half an hour to an hour. And so we've had virtually 100% of the moms who we've invited to do that say yes. So that was actually a design choice that we made because we were mostly interested in those data and understanding how how moms are experiencing the intervention, because we want to figure out what can we learn from that around how tech interventions need to get better from how, at least in this case, parents have engaged with this one. And then the control moms, we were kind of doing it just to get a little bit of a sense of, in the counterfactual, what were the other resources that parents were picking up on. And we do ask that in our survey as well that I'll tell you about, but it was sort of to kind of get a sense of whether the survey data had missed anything, if that makes sense. But yeah, we've kind of wondered if we did the right thing in that case around just having the 4, but that was the reason, so we could put our resources into like having a more robust range of experiences with the intervention.
Thank you.
Okay, but please, interrupt me. I really don't mind. I think I told some folks before they got in, I hang out with economists who will interrupt you mid-sentence. So I'm very happy with that model and prefer people to jump in. Okay.
If you don't mind, Gary Freed did ask one question earlier. So if we're stopped, this may be a good thing to ask. So this was more in your introduction. He said, although previous work shows an impact of those interventions, you're talking about different technology and interventions, how robust is the impact? What is the magnitude of the effect it has that has been shown?
Yeah, so generally pretty small impacts for sure. And some of them have no impacts at all, right? So we're talking about, I think that the advantage of this approach, we think, might be that it's very scalable and lower cost, right? Our folks are volunteers, for example, who are pretty engaged with the mothers, but aren't getting paid. So that's kind of the idea behind these, that we could really reach a lot of people before they're touching other systems. But one of the things we have to think about with nudge and kind of tech-based and in general is that we're not going to really move mountains. We're going to continue to need kind of more intensive interventions like home visiting. We don't see ourselves as like a replacement for that level of intervention ever. At best, maybe like a additional support for checking in with parents, like between visits or something.
So Christina,
yeah.
can I ask a follow-up question to that? Then
Yeah.
If the previous research shows modest or no impact, how much is enough to justify, even if there's a low expense, if there's no real impact, it could be free and it still doesn't matter. How much is enough to justify doing having a program like this? Not your research project, and I'm not asking that, but from a conceptual policy relevant standpoint, right? Because ultimately someone would have to pay for this if it continues beyond the research phase. How much of a response is enough to justify it?
Yeah, no, it's a great question. So in education and research, we think about this a lot, right? Because you can get some really small effects, like if you think of Dolly Parton's intervention where she gives books to families, you can get a small impact from something like that at a fairly low cost, but is that really worth it, right? And so that's where cost benefit analyses comes in with that kind of work. I don't know that we're kind of there yet enough to answer your question, just given how, you know, I decided that there are 48, but they're really different kinds of interventions, as you saw, around how they touch the parents and what they're doing. And we don't have really the evidence on how parents are engaging with them enough to know yet how to design them to be as effective as they could be. So I think that that's a really important and open question, at least in my mind at this point, as we think through cost analysis and cost effectiveness of these kinds of touches. I mean, I will say that most parenting interventions are ineffective and cost a lot more than this. Like the less intensive ones. I'm not talking about like parent-child interaction therapy or something where there's a more robust kind of literature. So I think if we can get any kind of positive effects and we're paying $1 a mom, that might be something that's beneficial, and you could scoop up more of them. I mean, we're working in the system, right, in the US, where we don't have something like, in most places, although there are exceptions like Durham, North Carolina, with universal home visiting, you know, we don't have a really robust support system for parents. So I think these tech interventions are just trying to step into that gap and try to help, given our really patchy support system. Okay, well, I'll keep going, but please do keep the great questions coming. Okay, so broadly in the project, we're following moms across 18 months, and I'm going to share with you the 4-month results so far today. But our research questions broadly is whether this intervention lowers mom's stress, increases mom's engagement in language activities with the baby, and increases mom's knowledge of child development at 4 months and 18 months postpartum. We also, at 18 months, we're aiming to bring the children in and directly assess their gross motor, visual reception, fine motor, receptive language, and expressive language skills. So that's now, so that's obviously not happening. So instead, we've built in some parent report measures of those things, and we're collecting those data now. In terms of process, we are also looking, as I mentioned, at how these moms are engaging with the intervention. How does engagement vary across mentors and across key mom subgroups like first-time versus second-time moms? And how do moms and mentors experience the program, and what do they perceive are its benefits? And this is mixed methods. So we do have these confirmatory outcomes that we will test the way we said, but we also have a bunch of exploratory things, especially since this is sort of like the first small randomized trial of this intervention. We really have other exploratory kinds of pieces we put in, and we want to learn from what we hear in the qualitative and transcript analysis about what's going on to connect those pieces and do some mixed methods analysis. Okay, so our key data sources here are that at baseline, before the moms are randomized, we have them fill out a baseline survey from which we take their background characteristics. We do a survey at 4 months in which we collect quantitative outcomes. We also get their hospital records in this postpartum period from 0 to 4 months. And we have the texting transcript. So every time the mom has touched the mentor, we have a record of it. And this is kind of neat for tech intervention. So I do a lot of work in preschool classrooms where we go in once and we get to see what the teacher is doing, or maybe twice if we're lucky. And here, this is kind of one of the only interventions I know where you literally see all of the details of every touch of the intervention. So I think this data is really interesting around the kinds of stuff we can get with these kinds of text-based interventions. And then the interviews, as I told you about. Oh, and it's 10 mentors. Sorry, there's a little mistake there. Okay, so in terms of our primary outcome measures, we, at 4 months, have the parent stress index long form, and we took subscales from those that the nonprofit and ourselves viewed as particularly salient to what they're doing. So we took the subscales for isolation, attachment, depression, child reinforcing the parent, parent competence, and total stress. And from the mom's medical records, we also have the Edinburgh postnatal depression scale. For mom language practices, we drew these items, which we administer in the form of survey to moms from 3 sources: the Metro Baby Study Survey, which was in New York City with a really diverse set of parents, the Early Head Start parent surveys, and the Ages and Stages 4-month questionnaire. We also have and we use that to make a self-reported measure of language and literacy practices the moms are engaging and how frequently they're doing so. For maternal knowledge, so we actually adapted a tool from Stephanie Reich at UC Irvine, which is called Opinions About Babies, which has content from the American Academy of Pediatrics guidelines, so basic things about child development that it asks whether the mom thinks a given thing is true or not. So we selected some items from her questionnaire with our NurturePA program manager to target the knowledge that they really aim to impact. So trying to get it specifically the pieces, because the measure is kind of broad. On the exploratory side, we also are using other measures of maternal mental health beyond the Edinburgh. So we actually just asked the moms around whether they had a postnatal anxiety or depression diagnosis and were getting treatment for that. For child development, we also asked about whether their child had been screened for EI, whether they qualified, whether the baby was reaching a particular milestones, and we summed those up, and then the number of difficulties that the mom has been experiencing in her own health and mental health and physical health in the postpartum period. We also took from the MOT scale that I mentioned, mom's experience of criticism, and we created a few constructs from this: the number of critics the mom reports having in her life about her parenting, whether she has any critics, and the number of things she feels criticized about. And then we also have a Likert scale in which for 2 items where moms have to agree with the general statement that moms get a lot of unhelpful advice and moms get too much blame and not enough credit. We also have some breastfeeding indicators, whether the mom is breastfeeding at 4 months, the number of resources she's used to support her in breastfeeding if she's chosen to do that and been able to, and then the quality of resources rating, so how good have those resources been. Our data analysis and our quantitative work is really straightforward. It's just a simple intent to treat regression model where we're looking at the impact of being assigned to a mentor. And here we have the maternal outcome of interest is that MAT-I you can see. Treatment is an indicator of assignment to the treatment condition. X is a vector of basic baseline characteristics. I'll show you those in a minute didn't want to stick them all on the slide. And E is the random error clustered by mentor assignment. So nothing too fancy here in terms of treatment control differences. We did find that about 10% of the moms who were assigned to treatment never really engaged with the program. So it's easy to kind of scale this up to engagement effects as well. But I'll show you today really focusing on the ITP. For our texting transcripts analysis, here we built off the analysis we've already done and published in our feasibility study. Our feasibility study was based on transcripts across 1 year with 160 mom mentor pairs, well before our randomized trial began, when we were just working with a nonprofit to see what the heck was going on in the intervention and did it seem to have any potential promise for moving any of the outcomes they were aiming to target. And in our coding scheme from that paper that we developed, essentially we break the text transcripts into different conversations that the parents and moms are having, and then we code what are they talking about. And we do so within a way in which we code or who initiated it, the mom or the mentor. What are they talking about? Are they talking about a problem? And what supports is the mentor offering the mom? And we did have good reliability here. So we have a 3-person coding team with above 80% reliability between the master coder and all the other coders. We also code the subsample of about 20 of the transcripts for accuracy. I won't talk about this today, but essentially we also make sure that a mom is, like, their mentor isn't going rogue and, you know, introducing a lot of old wives' tales or something like that, even though she's supposed to be taking this kind of proven information and getting it to moms. So that's something else that we monitor in the study. And in the feasibility study, this was not a problem. And we're seeing the same so far in the RCT as well. In terms of what are they talking about, just to give you a little glimpse of our coding system. So we're coding each of the conversations, and they can be about multiple things, right? So you can be talking about the baby's language and then halfway through ask about sleep. So this gives you a sense of what that codes look like, that we see things like talking about child well-being, and we code it that way, or siblings. Some of the things around basic care, feeding, et cetera, we do break into subcodes, as you can see, so we can get a little more descriptive. This is, and we developed that because we just saw a lot of rich conversations within those domains in particular. For the interview coding, I'm going to give you just a really brief picture of that. We are doing grounded theory with an iterative EMIC and EDIC approach, in which we have codes that are brought to the data from our feasibility study, but we also allow them to arise from the data and iterate back through. And we are now collecting the 18-month interviews, and so we'll do some integration across those time points as well as we work through getting all the data and getting it processed. Okay, so now I'm going to get into our findings. The first finding is one you always like to have in a randomized trial, which is just that random assignment did work. Great. So our overall F statistic shows balance here, even though we have some wiggles in some of these characteristics in terms of the treatment control difference. And those two, just to give you a sense of who's in the trial, you know, moms are about 29 years old on average. The majority are white, which is, this is the demographics racially are really consistent with the Pittsburgh area. There's a mix of income. About 71% of first-time moms in the treatment control versus about 58% for control, a scattering in terms of education as well. The diversity, most were cohabiting with the biodad. Some did have a baseline history of depression and anxiety. We also had reports that about 13% of control moms, 17%, or 13% of treatment, 17% of control had difficult pregnancies, and many had, a larger percentage had difficult deliveries. Okay, finding number 2, right? So attrition, how did that look at the 4-month time point? So we had about 14% of moms who did not complete our survey, which is what we considered as attrition at that time point. And for control, it was about 25%. So we do have some differential attrition between the two groups. We do some work that I won't show you today to adjust for this in about 4 different possible ways to see if the results seem to be affected by differential attrition, and we're getting pretty much the same story across those different checks. And the other thing to know about this is on all of these background characteristics, when we refit those models using the non-attrited moms at 4 months, we still maintain balance in our baseline characteristic, which is a good sign in terms of questions you would have about whether the internal validity of the experiment had been maintained. Okay, so in terms of what's going on in the intervention, this is with the 99 transcripts at 4 months to give you a sense of what we're seeing around engagement levels and patterns in the data. So at the 4-month time period, we're seeing that on average, there's an engagement of about 110 days, and max is 123 here. We also looked at the ICCs here are calculated based on how things are clustering by mentor, right? And that's important because we would hope that which mentor you get isn't a huge driver of your experience in the program. And for the most part, it's not, with the exception of the next one, which is the number of exchanges. So some mentors do appear to be more initiating of exchanges than others, which is, feedback for the program around how to improve their monitoring of the mentors. Mean length of exchanges. So this is like how long is your conversation, how many text messages. So it's about 3 on average. So it looks like, the mentor checking in, the mom responding, and the mentor checking in, although it ranges to up to 8 texts back and forth in the conversation. The mean time between conversations in days is about 9 days, which is pretty consistent with the feasibility study. The target here is once a week, so it's a little bit lower than we would like in terms of frequency, but not too far off the target. Most of the time, and this was true in the feasibility study as well, moms don't initiate the exchanges. It's the mentors who are reaching out. The percent of exchanges that address a problem, it's about 16%, but it can range to 73% of the time that they're having conversations. And the percent of problems that receive a response with some help from the mentor is about 88%. Okay. When we look at the content of what they're talking about within the treatment group transcripts, we see that about 43% of conversations do have a child-focused topic, 22% have a mom-focused topic, 56% have something else, and so that can be just kind of a general hello or questions about parent co-parenting, et cetera, with your partner. The percents here do sum to more than 100 because your conversation, it can include more than one focus. So you can talk about how the mom is doing and then a child question, et cetera.
Did you, sorry, do you mind if I ask a question? There's a high percentage of the other. Did you find any like patterns, or is it too early that you realize that there's something else that you should be addressing? Does that make sense? Were there any patterns in that other?
Honestly, I have to look back. It's a good question. We kind of just did this because we were like in this rough. I mean, we're going to do the 18 months and have the total. Yeah. But it's a good question since it's sort of the largest category. A lot of it is sort of like, how are you doing? We're doing fine. Really looking forward to Thanksgiving. I mean, so that's sort of like one where they're like building a relationship, but it's not really like getting to like, is the baby rolling over? Are you feeling depressed? Right. So that's kind of a lot of what we see.
Gotcha. Okay. I didn't know if it was like exposing it, like other things that maybe should be addressed that you didn't realize before. But maybe. Yeah. Okay. Thanks.
No, that's good feedback. So that I can see, we should break that down further in this slide. Okay. So we did see that about 69%, about 70% of moms had at least one problem that was discussed. And we saw mentors offering a variety of supports like advice, information, websites, and emotional support. Almost all the moms were offered at least one support, regardless of whether they discussed a problem with their mentor. And the average number of supports offered was about 20 across the 4 months of things that they're offering to help them through a problem, or in general, your baby's 2 months old, work on eye tracking activities, et cetera. And those common supports of the 20 included advice, activities, local resource information websites, and emotional support through a problem. So this is getting into those ITT impacts of what we're seeing. And these are our primary outcomes at 4 months. And so from isolation over to total stress, those are the ones from the parent stress index measure. And what you can see here is that we pretty much have things that are either really close to zero, like reinforces parents' competence, or looking like the mom is feeling more depressed if she's in the treatment group. And we see on the Edinburgh depression that the effect size here is about 0.3. I did just translate everything into effect size so we could show you everything on one slide quickly. Language activities, we're seeing that it's in the positive direction, along with opinions about babies, a measure of maternal knowledge, but none of these are statistically significant from 0. In terms of the exploratory outcomes, we are seeing things that, again, some of the magnitudes are sort of interesting and might suggest that there's more statistical power, maybe something is there. But we are seeing that more of the treatment moms are diagnosed with anxiety, and that's controlling for baseline levels of their anxiety, and that they're getting treatment for anxiety. We're seeing less EI screening in the treatment group, and we're seeing that babies are reaching more milestones in the treatment group, marginally statistically significant. Again, not statistically significant from 0, but important to look at magnitudes of where things are going. In terms of 4 months, we don't see any statistically significant effects on breastfeeding. Everything is in the negative direction, however, and not tiny, like quality of the breastfeeding resources they're rating is a little bit lower. Where we do see some things that pop out as statistically significant are more consistent in this story is that we have from the Mott criticism measure, the constructs that we created, we saw that moms, felt like there was some agreement that moms aren't given enough credit, that they're given a lot of unhelpful advice, and that the number of criticism targets is a little bit higher, like the things they feel criticized about. And this was sort of interesting to us. We don't really quite know what to make of it. We've added qualitative questions to the 18-month interview to try to really get into what's going on with moms in the treatment group who are feeling criticized. We don't know if perhaps one thing we've talked about is whether having somebody who's really unconditionally reinforcing you as a parent makes you more sensitive in the treatment group to little flags. So if you have someone who is saying, when, you know, someone in your family, for example, says, well, maybe you just don't have a good enough routine with this baby. Maybe you need to try more things, right? So maybe it's just making you more sensitive or making you realize the difference in the kinds of interactions that you have for others. Like, what is an unconditional supportive relationship like? But again, that's just one hypothesis, and we will have these same data at 18 months along with the qualitative interview data that we've designed to really try to inform this. Oh, I see I only have like 10 minutes left. Oh, this is sad. Okay, I'm gonna like just fly through the qualitative stuff really quick so that we can talk, because I'd love feedback on what you think of these quantitative impacts. We don't know, for example, if maybe 4 months is really just too early. We thought that would be a good time because that first kind of, you know, the 4th trimester, right? It's like a pretty stressful time. So it seemed like a good time to get to moms because that is one of the most stressful points of infancy is that first 4 months. The things haven't quite evened out in the way that they tend to at 6. But in any case, I would love to talk about it. So let me just tell you really quickly what we're seeing with the qualitative data. So at 4 months, what we're seeing, and this is focusing on the treatment mom transcripts, and I'm just going to go to the takeaways. We do see that strong relationships can be built through text, but they aren't always. So we see evidence that moms are feeling attached to their mentors in some cases, and others less so. So there is potential that you can have a relationship with somebody that you've never met and feel supported by them, that we see in the transcripts and here in the interviews. We also have reports that the fact that you never meet your mentor makes you more comfortable, that it's somebody who won't judge you. It's not public on the internet in the way it would be in like a Facebook moms group. And that's one of the things that they find helpful about the intervention. They do use it in really different ways and for different reasons. So some of them, it's like I go to that for the hard to Google stuff. I go when it's an emotionally charged parenting choice. I really find the emotional support validating and respectful, if that's why I do it. The program does make moms feel cared for. So this is another piece where they report that they really like that somebody's checking in on them, that a lot of times in this period that it's all about the baby, and that they appreciate that somebody is equally as interested in them and how they're doing. Okay. So our next steps, we are digging into all that 18-month data with transcript coding surveys underway. We expect to have all the data analyzed and reported out by September 2021. Okay, so now I can open it up to questions.
Thank you so much. Feel free to either like chime in and ask questions or just ask questions or like put it in the chat. I'll watch both. And before I forget, Dr. Prosser is on vacation. She apologizes for not being here today and sends her regards. So one question I had with recruitment, did you find it hard to recruit? I find that I'm planning a randomized control trial, and the more I learn about recruitment and the difficulties, the more intimidated I get. So what was your experience in the recruitment process?
So that's a great question. So the reason it took us so long to recruit our sample was our first clinical coordinator was just not that into us, I like to say. So she recruited very few moms. And so once we kind of worked out that issue with our clinical coordinator, who was a hospital employee with the hospital, and she ended up leaving the job because we weren't the only people she wasn't that into. She wasn't that into the job. Then when we got the new clinical coordinators who were much more into their role, it actually went really quickly. We are, although, not really asking for anything really invasive, right? Just text with this person, get these incentives along the way, get your questions answered. So I imagine that varies a great deal too by what the intervention is. But that was our experience, like that frontline person. Previously, when the intervention recruited in hospitals, they were in community hospitals, and they were able to send in their own very enthusiastic face of the project from the nonprofit. And so that person got very high yeses from mothers, and our clinical coordinator at first was getting almost no one. And so our subsequent more enthusiastic people did get more.
Yeah, I would think it would be like a low barrier. There's not much that they have to do. I would think as a new mom, there'd be no downside to it. Gary asked the question, what is your summary statement from these preliminary results? Encouraging, discouraging, expected, surprised?
I'd say I'm somewhat discouraged for sure. Again, I think the beauty of this project isn't ever just evaluating one program. It's trying to learn general lessons. And so in terms of the research and how we get better, and is this really a promising space, I think this project has a ton to contribute. I think it is nice to hear that the moms in our qualitative data really do like the intervention. They really feel supported by it. They're really willing to talk to us. And so I'm discouraged that nothing is showing up on the more standardized tools. I do wonder whether, one, it was too early at 4 months, even though I thought it would be a great time and recommended it. It's my fault. Or I thought, that some of this, given the track record of some of those tools, there was potential, but maybe those things, the tools just aren't sensitive enough in this case. I can think of other studies in early childhood where, for example, with math, which preschool math assessment you pick matters. And so maybe we just made not great choices on the sensitivity of the instruments for this intervention. But yeah, I would say I'm in that kind of discouraged, glad we're learning. And I think we'll definitely be able to make a contribution on this kind of intervention. And we'll know more at 18 months about whether we should be discouraged or whether it was too early it would take future trials to know if our tools just aren't sensitive enough. So that's kind of going to remain a question if this story continues to 18 months. I mean, if other people have takeaways they want to share about where they kind of peg this to, I would love to know.
One thought I had about the 4 months is like, I don't know, at least for me personally, and maybe for some of the moms, that you had like, it's after 3 months, you're going back to work. And so the 4th month is really hard because it's your first month trying to figure out how you're going to have a baby and work. So like all the pumping at work or the being sleepless at night, and then also trying to function at work during the day. So it's a big adjustment or potential big adjustment month for some moms, possibly.
I would say that for some moms, that's true. I think many moms, and again, I don't know for sure the patient population, go back to work at 6 weeks, and that there's a range of parents. I think sometimes we end up kind of in our own little world where everyone does sort of what we do. But as a pediatrician, I think that certainly those first 4 months for whatever proportion of the population that goes back to work at 6 or 8 weeks, which I think is a relatively substantive portion of the population, is a really difficult time for many people for the exact same reasons Courtney said. Just I think the timing is different for different people.
Yeah, and it should be balanced in the treatment and control group, right? That's the beauty of having these groups. And most of these are working mothers, just like in America. But yeah, I mean, we wanted to hit at a time when they'd be more stressed, right? You don't want to wait until now they're happy and everything's fine, because if you're going to reduce stress, you might see it when they're feeling more stress was the idea. But I don't know if maybe that wasn't the right choice. So.
The one thing that I would say about the preliminary results is that it's often difficult to engage in interventions where things may not work because they're disappointing and we have a lot of emotional energy vested in whatever the project is. And I think one of the most important things is to make sure that we go into this not as advocates, but as researchers, and we don't spend more time looking for the small potential impact that can make us feel better about it, as opposed to a realistic, view of what was the real impact of an intervention. And because sometimes things work and sometimes they don't, right? And that's why we do research, and we want people to believe what we do. And I say this for many of the junior faculty on the call, is that it's really important when you engage in research that is an intervention, especially one that you've designed, that you figure out ways to structure both a research design and an analysis plan to be able to determine with as much objectivity as you can impact, and be willing to say just as quickly something works as something doesn't work, and not simply spend all your time searching for the silver lining, which may or may not be the dominant finding.
Yeah.
I'm wondering if
pre-registration. I was going to say pre-registration certainly helps with that, and I think it's been really great for the field. And to be clear, we did not develop this intervention; the nonprofit did. So we are the external team that's kind of, reporting back to them on how things are going.
Yeah, even more important.
So one thing that I would add in the context of this conversation right now is in the US, as in everywhere, you start with certain understood facts about how women, just after delivering should be treated by our society, right? And what kinds of preparation, what kind of support is built in. Other countries deal with the same issue in very different ways. And I'm concerned sometimes that we say, well, given the facts as they exist currently, what can we do with it? So there are a lot of interventions with technology, right? Because scalable, once you have it down, low cost, et cetera, et cetera. Very often we don't start with the question, what would be the best way of approaching a problem, right? Don't start with what our system is like, because then we end up perhaps tweaking at margins, which gets to Gary's point that what would be the basis to expect them to have a truly high impact? I don't know, what are your thoughts on that, if I've made that point clear?
Yeah, no, I take the point really well that, you know, a lot of these things are kind of tinkering at the edges, right? And so to me, there are folks who are doing that, like the Durham Connects, where they have universal home visiting in Durham. They have it in, they're spreading it to many other states like Washington State, Oregon, et cetera, that kind of model, and trying to learn from it. So it's sort of, it's always a hard thing, because you would like to have a different system, but you don't. So what do you do in the meantime, right? And I think there's kind of room for all of it. And I'm not, I guess, like, when you see a proliferation of these things, I think they're worth learning from, right? So that, you know, the Ypsilanti Library, maybe you didn't know, but they have a texting intervention for parents. Like, these are everywhere. Parents are experiencing them in the world. If they don't work, if we shouldn't be tinkering at the edges in the way we are, I think that's an important message to give people in the field as well. So I think it is worth doing, that we can do multiple things. So I guess that would be my response to that piece of things. Like, I'm the author of a book, Cradle to Kindergarten, which has a chapter called No More Tinkering at the Edges, and advocates for like large policy reforms from the 0 to 5 period. But that's, I can tell you, we've been working with several states on that for 3 years, and it's a really long process. And so there's probably room in the middle to learn from other things as well, when, you know, maybe the Biden administration we wrote the book for the Clinton administration. That's another kind of long story. And maybe it'll get traction now. But you know, you have families that are going unserved while you're waiting for all of the bigger changes.
That's a great point. So it is 10:03. I thank you so much. This was really interesting work and relevant to a lot of us. So we really appreciate it, and appreciate the work that you're doing for kids. And thanks for your time. So great to see everyone. And we'll see you next seminar next year. All right.
Yeah, thank you so much. And please send any other thoughts by email. Again, work in progress, would love the conversation and feedback.
All right. Thanks, everyone.
Weiland. Bye.